right, so I guess I'll get started. I'm Lauren Cameron-Comasco. I'm from Beaumont Health outside of Detroit, and we're going to talk today about Elderspeak and discuss some strategies to enhance communication when talking to your older adult patients. I have no conflicts of interest to disclose. So our objectives to talk about and define the concept of Elderspeak. We'll talk about the effect that Elderspeak has on our older adult patients in the emergency department and discuss some alternative tools and strategies to help strengthen the therapeutic relationship between you and your patient. So we'll start with informal poll. You can raise your hand if you've heard of and understand the topic of Elderspeak. So if you have, raise your hand. Okay, good. And if you haven't, can you raise your hand? Okay, good. So for those of you who are familiar with Elderspeak, that's great. I hope to add some additional tools to your toolbox. And for those of you that have not, I think that you'll realize that you see it happening more often and just maybe didn't put a name to it. Moving forward, have you witnessed or have you done this yourself, use a term of endearment when speaking with your patient? So if you have, raise your hand. I know I'm guilty of it as well, right? And I think most of us are. So Elderspeak, this is probably the most comprehensive definition that I've come across, and we'll break it down. But it's a form of communication over accommodation that's used with older adult patients. It uses inappropriately juvenile lexical choices, exaggerated prosody, and it arises from implicit ageist stereotypes. It carries the goal of expressing care, exerting control, or facilitating comprehension. And we found that it may lead to negative self-perception in older adults and challenging behaviors with patients with dementia. I do want to point out that most of the time when users speak in Elderspeak, the intention is always to show care and concern in our subconscious. But however, it's not always perceived that way. So examples of Elderspeak in medicine, we see it in our content of our speech, the speech delivery, and then our nonverbals. So our speech content, we mentioned the terms of endearment, honey, sweetie, dear. There's also the collective pronoun substitute, such as we need to use the bathroom or we need you to take your medication. And by using this collective pronoun of we, we're really taking away the individual and their own autonomy. Your speech delivery, are you using like a very high pitch vocal adjustment or an over-nurturing voice? You can use exaggerated intonation, lots of smiles, nods, or short, slow sentences. Are you standing, kind of bending over the patient in the stretcher, or are you at eye level speaking with them? Are you patting the patient when you talk to them? These are all examples and features of Elderspeak. The feature alone does not really fulfill that criteria. You have to have multiple features to really show Elderspeak, essentially. So kind of a nice example to put it is a patient's in a stretcher, they're slumped over, and you come in and you're like, hi, I'm Dr. Cameron. What brings you in today? You know, when you're leaning over speaking or screaming into them. And I see this probably, multiple times a shift, whether it's with, aides, techs, nurses, residents, APPs, or other colleagues. I'm guilty of it myself. So why does it occur? Why do we use Elderspeak? It really originates, or the theory is in the communication predicament of aging model, and that is rooted in old age cues. So what are old age cues, right? Does the patient have white hair, gray hair? Are they balding, thinning hair, loss of muscle mass? Have you determined that they're frail? And from those old age cues, we then create our own expectations of what we expect the patient's cognitive ability to be. Perhaps if you see a walker at the bedside, things like that, you expect that they might not be as independent with our IADLs or ADLs. And due to these expectations, you then adjust your speech and behavior adjustments based on these old age cues rather than your individualized assessment of the patient. And then from that, we see just this cycle of reinforcing your age stereotypes. So what do patients think about Elderspeak? Research is variable. Most of the literature is found in nursing journals, but overwhelmingly, community-dwelling older adults and nursing home residents have found to dislike Elderspeak. They rate caregivers as less nurturing, less respectful, less benevolent, and individualized studies really looking at what aspects of Elderspeak is improving or disproving the patient's ability to comprehend or recall really hasn't shown anything solid, essentially. We've looked at using shorter sentences, speaking slowly with a higher pitch, and there really hasn't been any consistent data to show that it's helpful at all in comprehension. In fact, older adults perceive a decline in comprehension even if it has improved or if there was no change. So when we use Elderspeak in our communication with older adults, they think you're speaking to them because, they're dumb or they aren't as cognitively intact. Recent studies have shown that Elderspeak leads to resistiveness to care, specifically in patients with dementia in nursing homes. There have been randomized trials that look at the relationship between Elderspeak and resistiveness to care, looking at the implementation of education, comparing caregivers that received Elderspeak training and those that did not. And they found that the patients that had caregivers that were educated in Elderspeak had a subsequent decline by about 14%, and patients with dementia saw a decline in resistiveness to care by 15%. Follow-up study was done looking at nursing homes that received the training and saw that there was a reduction in antipsychotic medication administration. Also looking at, again, patients' perception to Elderspeak, nurses' speech was perceived as less controlling and more respectful after the training. So that's the Elderspeak portion. What we know that there's not consistent evidence to support the use of Elderspeak, but what can we do to improve our communication with older patients? Are there some barriers to communication, or what are the things that kind of prohibit you from having a good discussion with patients?
Sometimes they don't have their hearing aids or they lose battery, and so that kind of makes it a little bit more difficult.
Yeah, absolutely. I think, oftentimes we end up, screaming, yelling at the patient in attempts for them to hear us. But what we're really doing is kind of taking away that dignity that they have. Oftentimes they come via EMS without their hearing aids, or they're just out, not in their ear at the bedside. What we can do, right, is encourage, if we know the patient's going to be admitted, the family to bring their hearing aids to the hospital. But in the case that you don't have that, there are hearing amplifiers. They're about $10 to $15 depending on supplier, and you can provide those. We have those at RED, and they're like an AirPod. They're attached to a microphone. You stick the earpiece into the patient's ear. You talk directly into the microphone, and they're very effective. We use them in clinic often, and I think that this is a huge opportunity for departments to really recognize how we can better address these hearing difficulties. Another barrier to communication that we found, especially with COVID, is masking, right? A lot of older adults rely on lip reading to communicate. Masking also can muffle your voice. So, another opportunity. I don't think we found a great solution. One of the ideas and ways to mitigate this is for patients with hearing aids to use the masks that double tie rather than go around your ear, because you can't wear a hearing aid and a mask that goes around your ear comfortably. In this case, you might have to slow and use some features of Elderspeak when speaking with your mask in order to ensure that the patient can understand you. So that might be an outlier, but an opportunity certainly to see how we can do better. So here's a table, kind of instead of doing this, do this. And I think that really the opportunity that you have to create a therapeutic relationship is in the first seconds to minute of when you walk in the room. The patient has to be able to trust you and trust that you are the person that's the best to take care of them. And it starts the moment that you walk in the door. Creating the optimal environment is paramount, and I think that really starts with walking in and introducing yourself. Again, this looks on the table. You see, instead of calling the patient dear or sweetie, or using these terms of endearment, refer to them by their name or their preferred name. When I walk into a room, I say, "Hello, I'm Dr. Cameron, Mr. or Miss last name. What brings you in today?" Another strategy is, "Hi, I'm Dr. Cameron. What would you like to be called?" That way you're opening the patient up to tell you what their preferred name is. And that's a strategy I think that a lot of people find to be successful. But when in doubt, always use a formal, or ask them what they would like to be called. Another kind of step to kind of creating the optimal environment is to turn the lights on when you walk in the room. We know that emergency departments are breeding grounds for delirium, and by interviewing the patient in the dark, you're really not able to see them. They cannot see you, and by leaving a light on in the middle of the day, that's also messing with their circadian rhythm. So turn on the light during the day, leave the light on. If it's the evening, turn it on when you interview, turn it off when you leave. But you should not be interviewing the patient with the lights out. A lot of us have the luxury of having televisions in our EDs, which is great, but that should not be on while you're having a discussion with the patient. The sound, the lights, the visual is a distraction. So turn that off while you're having your interview. And then, again, making any assumptions about the patient's ability to communicate. Really, we should be doing an individualized assessment, kind of checking our bias at the door and seeing what the patient's actually capable of by talking to the patient. They might have their care partner at the bedside, and it's great to acknowledge them. You should. I suggest doing that by asking the patient, who is this in the room? I would avoid the term relationship, or how is this person related to you, or what is your relationship? That can be triggering for some patients, but give the patient the individualized opportunity to tell you who that person is to them. We mentioned yelling and or talking into the patient's ear, and then the other strategy is really the patient should be comfortable. The patient shouldn't be slouched or falling off of the stretcher during your encounter. When you walk in, again, optimize that environment. Lights on, TV off, introduce yourself, give the patient that autonomy as an individual, and then optimize their situation as far as in the stretcher. I know it makes me uncomfortable to have a conversation with a patient that's falling off the bed. So really that needs to be addressed prior to the remainder of the history and physical exam. So the takeaway is that proper communication is crucial to the management and treatment of all of your patients. It's best to avoid Elderspeak, and understanding that these old age cues really just reinforces these ageist stereotypes and can lead to our over-accommodation in speech. By engaging in a person-centered communication strategy and an individualized approach, you can help create a better therapeutic relationship with your patient and enhance that communication. And I would suggest, if you see Elderspeak happening, which most of us do on shift, to educate your nursing staff, your students, your APPs, your colleagues on kind of the dangers of Elderspeak and how we can all do better. Any questions? Yeah, hey.
Implemented translucent masks to accommodate lip reading?
We haven't. We have talked about it, but we haven't had the buy-in to be able to do that. Have you? Or do you? Really?
It really helps.
Okay, great. Maybe, Jay, we can talk about a supplier because that would be helpful. That was a barrier that we had as far as changing suppliers and getting that, but that would be great if we could follow up.
Any tips on, I love your tip slide, by the way. That was a game changer. That's great. But how about with Marty? I mean, this is where that's a communicator that I feel like, I don't know how we can get, they just don't even understand the concept. I'm talking to a TV. They can barely hear it. It's just always problematic.
Yeah, I think that in that kind of cohort, that age group, it might be better to use a blue phone. They're very familiar with phones. It's right directly in their ear. We have them available. Most places do. If you just have the Marty, I mean, I think we all can just do the best that we can in those specific circumstances, and then it might be helpful to get a family member. But I think the blue phones, given that age group, would be helpful. Anybody else? Thank you. Yeah.
When they are hard of hearing and you don't have access to like a hearing amplifier or their
Right.
hearing aid, how can you talk loudly without sending that?
Right. Well, I think that that's an opportunity to educate your department on the importance of hearing amplifiers because they're very, very cheap and helpful, right? Giving patients their dignity is important. But obviously, if you have to be able to communicate to them. And in that case, yes, you have to talk louder. I would just caution you, instead of bending over or screaming into their ear, is to sit down at their level, get close to them, and talk to them. Yeah.
What are some ways to help with the patient autonomy when, like, they have a family member in the room that keeps on trying to talk over them,
Yeah.
contradict them?
Right. I think that's a great question. I often will kind of see how it goes. I speak directly to the patient. I introduce myself. I ask the patient to just tell me who's with them. I'll say hi. Sometimes I'll preface, depending on kind of, you read the room. I'm going to talk to your mom, and then we can talk afterwards if she's okay with it, and just see how it goes. You'll ask the patient a few questions. If they are unable to give you a history, you pick up on it, right? If the history that they give is different from the caregiver, which can happen in patients with dementia, that's early on, as they compensate really well, and they'll start telling stories to make it make sense, even though it's incorrect. Family at the bedside can often redirect you or afterwards say, hey, this is not exactly how it's going. But I give the patient the initial opportunity. If the family is very insistent on being the one to provide the history, I usually ask them just to stop, and I'll address them when the time's right. And usually they're very responsive. I'll finish with the patient, and then I can close the loop. Hey, you're doing a great job. I appreciate the fact that you're here, and the history you provide is essential. I just needed to get a good assessment of the patient first, and then usually they're very understanding. They want what's best. If they're doing that, they want what's best for their loved one, and just showing them that that's what you want too. It's usually well received. Great, thank you.